We are going to talk about ventricular dysrhythmias and other life-threatening dysrhythmias such as PEA. Here are your objectives.
We're going to talk about ventricular and life-threatening dysrhythmias. And ventricular dysrhythmias are going to be more life-threatening or potentially life-threatening than your atrial dysrhythmias because we get most of our cardiac output from where? Our ventricles. So with ventricular dysrhythmias, they are going to affect the P wave. You're going to see a wide and bizarre P waves. And some of them include PVCs, idioventricular, accelerated idioventricular, and here are the ones I want you to know: vtach, both your monomorphic and polymorphic, which will include torsades, Vfib, PEA, and asystole.
Premature ventricular contractions, or PVCs, can be harmless in nature, but again, they can be precursors to some of your more fatal dysrhythmias such as vtach or Vfib. And they can be caused by things such as hypoxia, myocardial infarction, cardiomyopathy, electrolyte imbalances, hypertension, recreational drug abuse, alcohol, stress, caffeine, and stimulant use. And they ultimately, your treatment is going to be treat the underlying cause. Sometimes you'll see medications to help balance out the membrane, such as calcium channel blockers, are going to be given. And it's important that you understand that there are different types of PVCs. And there can be couplets, which are going to have two PVCs in a row. Or you can have bigeminy. That's where every other beat is a PVC, like we see in that first rhythm. Then you can have trigeminy, and that's where you have a PVC every third beat. Again, as I said, PVCs are usually harmless, but when they become a precursor to a more serious rhythm such as vtach, that's when you definitely need to worry. So you need to watch and monitor PVCs closely. Is the patient having symptoms with them? How often are they occurring? What is the underlying cause? Because you know, if you have 3 PVCs in a row, guess what that's called? vtach. And PVCs can be unifocal. That means they're all going to look the same. And when they're unifocal, that means they're going to look exactly the same. Or you can have multifocal PVCs, and they're going to each look different because they're originating from a different place in the ventricles. And so let's look at this rhythm at the top. When we're looking for ectopic beats such as PVCs, remember we have to first analyze that underlying rhythm. And it can get tricky, especially when you have frequent PVCs or frequent ectopy, such as your bigeminy or your couplets. So let's look at this though and try to figure out what's going on. All right, I've noticed that I have these normal looking QRSs that march out, but then every other beat I have this crazy and bizarre and wide QRS complex. I noticed that my PR of interval is normal. I noticed that I have a P wave before every QRS. It's upright, uniform, and consistent. I noticed that there just seems to be an issue with our regularity, so it looks pretty irregular. And some of my QRSs are very odd looking. But if I look at the rest of the rhythm, it looks basically like sinus rhythm. So here we have sinus rhythm with bigeminy unifocal PVCs. You notice that The beats that don't march out, or the early beats, are the ones that have the wide and bizarre QRS. Now, remember, our SA node is our default pacemaker of the heart, and its inherent rate is 60 to 100 beats per minute. And if the SA node fails, the AV node will take over, and we'll have a junctional rhythm. And that inherent beat is from 40 to 60 beats per minute. Well, if both our SA node and our AV node fail, we have one last ditch effort to produce a heartbeat, and that's in the ventricles. And remember, that inherent rate is 20 to 40 beats per minute. And when this occurs, we are going to go into idioventricular rhythm. And this is just going to be a ventricular rhythm that's going to be characterized by no P waves and very wide and bizarre QRSs. Now, just like with our SA and AV node, how it can beat out of its inherent rate, so can the ventricles. When the ventricles speed up and when they beat 40 to 60 beats per minute, this is called accelerated idioventricular. It is the same thing as your idioventricular, except it's just a little faster. And lastly, I want you to think about what happens when you have the really fast version of this. That's called vtach. And that's one of our life-threatening arrhythmias. Remember, technically 3 PVCs in a row is vtach, and vtach can be non-sustained. That's where a patient has a run of vtach, and then they convert spontaneously back into an organized rhythm, such as sinus rhythm, Vfib, a flutter, whatever. Or vtach can be sustained, and that is where the patient has that run of vtach that is not converting back. And sustained vtach is generally going to be more severe than your non-sustained vtach. And just like with our PVCs, vtach can be monomorphic, meaning the ectopy is coming from the same spot in the ventricles, or it can be polymorphic, and that's where it's going to look very odd and different. And that's because it's coming from different areas within the ventricles. And ultimately, when you see a patient in vtach, the first thing I want you to ask yourself is, does this patient have a pulse? vtach can present with a palpable pulse, or you can have pulseless vtach, which is considered cardiac arrest. So you need to check a central pulse, such as the carotid or the femoral pulse. And remember, you're going to treat vtach differently depending on whether there's a pulse or not. And with vtach, a patient may have a pulse and a blood pressure for a limited time, but if it becomes sustained, they will eventually lose consciousness and the pulse will no longer be palpable, and they are in cardiac arrest. When a patient goes into vtach, we know that the priority assessment is to determine if the patient has a palpable pulse. So you're going to check the central pulse, such as the carotid or the Vfib. If a patient has a pulse, then you need to determine if they are stable or unstable. And we're going to look at things such as, is the patient hypotensive? Are they decompensating? If a patient is stable, we want to go with the least restrictive treatment, which is going to generally be an anti-dysrhythmic, such as amiodarone. You'll see that an amiodarone bolus is given, followed by an IV infusion over the next 24 hours. Now, if a patient is unstable, showing signs of imminent danger, we don't care about least restrictive versus invasive. We need to go straight to unstable versus stable. And our goal is going to be immediate cardioversion, because if we do not convert this patient, they are going to lose that palpable pulse and go into cardiac arrest. Now, when a patient has vtach without a pulse, we no longer think ABCs. We go straight into CAB, compressions, airway breathing, because remember, even high quality CPR is only 1/3 as effective as a beating heart. So we need to immediately begin CPR. But our priority intervention is going to be defibrillation. So you never delay defibrillation because of CPR. So let's say put the pads on the patient. You're going to obviously start CPR first. But once you're ready to defibrillate, you immediately need to clear the patient and shock them. You will see that medications will also be given. Epinephrine first, followed by a bolus of amiodarone and another bolus. You'll go from 300 to 150. And ultimately, though, what's your priority intervention? Defibrillation. So, what is ultimately the most important thing? Defibrillation. And remember, defibrillation is like cardioversion, except it's just not synchronized. There's nothing to synchronize it to because you're dead. So, defibrillation is for dead, cardioversion is for not dead. On the previous slide, I showed you monomorphic vtach, and that's going to be vtach that originates from the same spot within the ventricles, and that's why all of the waves look the same. Well, torsades is a type of polymorphic vtach. That's why it looks all crazy, because it's going to be originating from different places in the ventricles, specifically with a widened QT interval. And things that can cause torsades can include, first of all, low mag, low mag, low mag, low mag, low mag, low mag, more low mag, certain medications, drugs, low calcium, congenital anomalies. Some people have long QT syndrome, but ultimately, I want you to always go back to mag and more mag. In the clinical setting, our patients are going to be complex, and often they have various disease processes and are going to be prescribed multiple medications. And a lot of times they may be prescribed multiple medications that can affect the QT interval or cause QT interval prolongation. So, a lot of times before beginning therapy and during therapy, we may monitor the patient's QT interval to see if it is increasing. And we have to look at the risk versus benefit in situations like this. Obviously, we know women have a slightly longer QT interval, up to 460 milliseconds is normal. But if a patient has very mild QT prolongation, like it's 460, 70, 80, we likely will not discontinue this therapy. However, once our QT interval starts hitting around 500 or more, that's where you have to think about the risk of them going into torsades versus the benefit of that particular therapy. Is there an alternative? And medications that are known to cause torsades can include antidysrhythmics, antibiotics, antipsychotics, antidepressants and diuretics, antiemetics, and antifungals. We know medications such as azithromycin, Zofran are definitely known for this. So just be aware of your medications and the ones that can affect that QT interval. And you need to make sure that the patient isn't at additional risk factors for torsades. Like you don't want to combine multiple QT prolonging drugs with low MAG. That's just a disaster for torsades. It's coming. It's coming. MAG, MAG, MAG. Remember, MAG. Remember, torsades is just polymorphic vtach, so patients can present with or without a pulse. And ultimately, if a patient is in torsades, your priority intervention is going to be give magnesium. You don't need to sit there and look in the chart to look at their magnesium level. The provider will be like, give 2 grams of mags IV stat. And that's just because most of the time, torsades is going to be associated with low magnesium. And remember, a patient can lose a pulse, and that's when you go with your CPR defibrillation. But if it's caused by low magnesium and IV magnesium is not given, it's going to be useless until we fix that underlying problem. So here, your priority intervention is going to be magnesium.
Vfib is the most common out of hospital presentation of cardiac arrest. In hospital, it's going to be PEA. But what's going on is the same thing that's going on with AFib, but this time it's in the ventricles. So your ventricle is having some type of electrical anomaly and it is not pumping. It is just quivering. So you have no cardiac output. So this is a form of cardiac arrest. You need to immediately start CPR. You need to shock the patient and follow your ACLS protocols. You will give epinephrine and amiodarone as presented in that algorithm.
So, just like with vtach, Vfib is a shockable rhythm. So, your priority intervention is going to be rapid defibrillation. And although we might start CPR first, you should never delay CPR. The priority or corrective intervention is going to be that rapid defibrillation. We are also going to give CPR for 2 minutes nonstop, and then we will give medications, epinephrine, every 3 to 5 minutes, and we can also give amiodarone following epinephrine because it is a shockable rhythm. So, epinephrine is for everyone in cardiac arrest. And remember, defibrillate is for anyone who is dead in a shockable rhythm, such as vtach or Vfib.
Pulseless electrical activity, or PEA, is a form of cardiac arrest. And this seems to be the most difficult for nursing students to fully grasp because there will be an organized rhythm on that monitor. And sometimes it can look pretty good. It can almost look like sinus rhythm, but the patient has no mechanical function. They don't have a pulse. And that's why you need to go physically search for a pulse, because just because they have an organized rhythm does not mean the heart is responding to that electrical conduction. So, obviously, you want to start CPR. And with PEA, a lot of times it is going to be reversible. So we have something called our H's and T's that we need to begin assessing immediately as we are delivering CPR and epinephrine. This is another non-shockable rhythm because we have electrical activity. It's organized. That's the only thing we have going for us. So why would you want to stop that? Now, your H's and T's are going to be things like hypovolemia, hypoxia, hydrogen ion, which is acidosis, hypo or hyperkalemia, hypothermia. Now, your T's are going to be that tension pneumo, cardiac tamponade, toxins. That's going to be your overdoses. A thrombosis, aka a PE or a MI. Don't you just love when you're watching a medical show and you see them shock a systole? I just want to throat punch all the actors, the producers, the writers when I see that nonsense. Now, we just talked about PEA. So with PEA, we have electrical activity, so some type of organized rhythm, but no mechanical function. Well, let's take it a little further with a systole. We're not going to have any mechanical function, but we're not going to have an organized rhythm either. Now, occasionally you may see a QRS complex that looks very wide and bizarre try to pop up, but there's going to be very few of them, and there's going to be no cardiac output generated by them. So let's go ahead and just try to see if we can interpret this rhythm, even though it's not going to be required for this course. All right, let's look at that rate. None. Let's look at that rhythm. None. P waves. Hey, ain't never heard of them. QR interval. What's that? QRS. Nope. So we know that we're in a systole based on this. Now, since we don't shock a systole, the treatment for this is going to be epinephrine, and we're going to pray that the heart wants to just start up. And we're going to administer high quality CPR to try to perfuse the organs while we attempt to work on the heart. Of all of your cardiac arrests, asystole seems to have the worst outcomes, probably because your heart's not doing anything at this point. And while you are doing this, you do want to assess those H's and T's, those reversible causes, because ultimately that's all you got going for you, that and epinephrine. Now, the reason we don't shock asystole is, why do we shock? We want to stop the heart so the SA node will hopefully take back over. But there's nothing to shock. All you're doing is wasting your time because the heart's already stopped. There's no electrical activity to stop. Talk to you a little bit about artifact. Artifact is going to be something that is going to interfere with our ability to see what is really going on. And this can be caused by a variety of different things, such as body habitus or hair, patient movement, patients that are confused. They're going to rip off all their leads, all their clothes. And often I hear nurses saying, well, that's artifact. That's not real. Well, if that's not real, what's really going on? Is what's really going on worse than that? So it's very important that you go in, assess the patient, and then the monitor, because they could be in a life threatening dysrhythmia and you wouldn't know until you go look at the patient and check your leads and see what is causing that artifact. Often it can be caused by things like improper lead placement. If we have a lead, one lead is off, it can totally throw everything off. The wires may have become disconnected, or your patient may be in cardiac arrest. You never know. So go look at the patient. All right, guys, that is the end. You made it through.